the efficacy of cabergoline and domperidone to mitigate prolactin-associated cycle. Problems in the state of africana. I apologize.
Thank you. Dr. That's okay. Get it done. Okay. Awesome. Okay, well, thank you. Good morning. Okay. So this morning I'm going to talk about treatment of a lot of acyclic female zoo-kept African elephants in North America that seem to have this prolactin-associated ovarian cycle disturbances. So in 2002, from 2002 to 2008, there were 3 reproductive assessment surveys that were carried out in this population of animals in AZA-accredited zoos. What we saw, particularly in our reproductive age females, and these are females that are between 11 and 35, in the Africans but not the Asian elephants, this alarming trend of reproductive cycle abnormalities. So these females were either not cycling at all, and we call them acyclic or flatliners because of their progestogen profiles, which I'll show you in just a moment, or they were cycling irregularly. So from 2002 to 2008, we ended up with 41% of our reproductive age females that fell into this category. So just to show you what that looks like, this would be indicative of a normally cycling female, and these are the progestogen profiles. You see them increasing during the luteal phase of the estrus cycle, as we just saw, so that was a great segue into this work. Irregular just means just that, right? It's irregularly cycling, and then here's our acyclic females. They're not cycling at all. So Brown et al. In 2004 wanted to look at concentrations of serum pituitary, ovarian, thyroid, and adrenal hormones, comparing these acyclic versus cycling females to see if there were any differences that we could discern. So looking at 10 hormones, there were 3 that really stood out as being different, and we're going to focus on prolactin here. So unique to this, in the Africans again, but not the Asian elephants, you see this is the Asian elephants cycling versus non-cycling, here's the Africans. We noticed that in these non-cycling females, we had a significant increase in serum prolactin concentrations. So, as was just discussed, there's actually a lot more differences than we would think between the Asian and the African elephants regarding reproductive cyclicity, and prolactin is one of them. So just to point out, this is our estrus cycle here, whereas 0 on this graph means time of ovulation. Anything preceding that would be during the follicular phase, where we have follicular development and maturation. Anything following that then would be the luteal phase, where we've had ovulation and we see an increase in those serum progestogens from the developing corpus luteum. But in an Asian elephant, normally cycling, prolactin stays at this baseline concentration. Not so much with the African. Here we see an increase during the follicular phase with prolactin. So in other species, we know that prolactin can participate in follicular development and maturation, so we can suppose that this may be what's happening here. Moving forward with this work then, Dr. Brown and myself in 2012 decided to go back and look at these acycling females, and particularly look at prolactin. Again, we compared it with our normally cycling and our regular cycling females. We looked at it over a year. And we found, once again, that in our acyclic females, we had significant increases in serum prolactin. But we could take it a step further. We could take those acyclic females and we could further categorize them as having extremely high prolactin, so this is hyperprolactinemia, or a prolactin deficiency. So they were on both ends of this prolactin spectrum. So again, this is just showing a representative profile of our normally cycling females. We don't get to see this very often in captivity, so this is a gem. So the prolactin is the triangles, the progestogens are the squares, and we just see the beautiful cyclicity over the weeks and repeating cycles. This is indicative of a hyperprolactinemic female. We see that flatlining of our serum progestogens, and then we see this chronically high prolactin that's held. And then this would be our low prolactin females. So again, our baseline progestogens or flatlining progestogens, and also a very flat line in regards to the prolactin as well. So when it comes to prolactin, this is an anterior pituitary hormone. It's held under constant inhibitory control by a hypothalamic neurotransmitter called dopamine. This can be overridden, this mechanism, by estrogen, produced, for example, by developing follicles during the follicular phase. We know that prolactin has been known to either be a primary or secondary role player in a variety of physiological mechanisms, particularly those that regulate reproductive function. So certainly in another species where we see a high incidence clinically with hyperprolactinemia and low prolactin or prolactin deficiencies are the humans. And so with this, it has been shown, has been proven, that with the use of either a dopamine agonist or an antagonist, prolactin concentrations can be normalized. And so that's the approach that we took with our elephants. So just so we're all on the same page, a dopamine antagonist is going to antagonize or compete against endogenous dopamine. And in doing that, it binds to the dopamine receptors and allows for, or I should say blocks, stimulation of these receptors, with the idea then being that we would decrease the inhibitory control of prolactin and thereby increase the synthesis and secretion of prolactin in systemic circulation. Cabergoline, for example, is a dopamine agonist, and here these agonists mimic the action of dopamine, thereby increasing the inhibitory control and decreasing prolactin in systemic circulation. So our first treatment was for these hyperprolactinemic acyclic females. So we had 8 of them. We dosed them with a dopamine agonist, cabergoline, which was given to us by an in-kind donation by Pfizer Pharmaceuticals. We separated our group into 4 and 4. We did have a dose established previously in our lab that worked with the regulation of prolactin in these hyperprolactinemic females. So the dose that we chose to use was this. So it was 2 mg twice weekly for 52 weeks. In our treated females and in our control, we gave a vehicle twice weekly for 52 weeks. The vehicle was a vegetarian capsule that was filled with dextrose. Our expected results then was that if we could normalize prolactin concentration, we could possibly restore gonadal function. In the human, it's been shown with hyperprolactinemia and prolactin deficiencies that if these conditions are held chronically, they do have adverse side effects, health effects. And so if this was happening in the elephant, we could reduce those by normalizing prolactin. So what did we see? So our control group, this is overall serum prolactin, and then I'll show you some individual elephants. Our control is in orange, our treatment group is in green, and what we noticed that almost immediately within 2 weeks, we had a significant decrease in the serum prolactin concentrations in our treated versus our control elephants. And this is just showing that 52-week treatment period. Looking at serum progestogens, we saw a significant increase over treatment period in our treated females versus our controls. However, we could not see any discernible cyclical patterns that would indicate that we did restore gonadal function. Looking at an individual elephant, a treated cow, again, we see this immediate response to that drug, which tells us that it is a similar mechanism for regulation by these agonists in prolactin secretion in this animal. But I want you to, and also we had a really good response. We see some patterns versus what we had before. But I want to point out that as soon as we withdrew that drug, we immediately had a fall of progestogens back to that flatlining. And then we also seen prolactin that increased as well to the concentrations that we had either before treatment or above that. And this is just showing us in a control cow. Another thing I want to point out is that in our 4 treated females, we did have 1 that did not respond to treatment at all. In our prolactin deficient females, again, we divided them up. We had 8 of those. We divided them up into treated and control groups. We chose to use domperidone or equidone. This was supplied to us by Equitox, and Equitox was a company that was owned by our second author, D. Cross. And this was also partially funded by the Morris Animal Foundation. So within this manuscript, we actually had to come up with a dose regimen for this. And so I'll show you that in just a minute to prove that it did work. But we came up with a 2 gram per day for 4 weeks, followed by an 8-week no treatment for 52 weeks. So if you remember that profile that I just showed you on the African elephant, we have prolactin that increases during the follicular phase, decreases during the luteal. So that's what we were trying to mimic, and we saw efficacy with that in our preliminary trials coming up with this dose regimen. Similarly, we gave a vehicle for the same schedule. Again, we wanted to try to normalize prolactin, and by doing so, restore gonadal function. So this is just showing that when we came up with the dose regimen, giving that medication, we did see good response to that following that regimen. And in fact, this was beautiful in this, that we had a female that we did restore gonadal function in. But how did that work then when we had our larger group? So again, looking at treated versus controls. Controls are once again orange, treated are green. This is when we had them actually given that drug for that 4-week period. We had a response. We had a significant increase in serum prolactin concentrations in our treated versus our controls, so the drug did work. But we saw no changes in our serum progestogen concentrations. Once again, this is looking at a representative profile of a treated individual, and we see that we definitely had response to the drug, and then this would be our control. Similarly to what we had with our cabergoline-treated females, we also had one elephant that did not respond to treatment in our domperidone treatment. So where did this leave us? Well, we certainly know that in these acyclic females, we do have the commonality of significant perturbations in prolactin. We either have high prolactin or we have low prolactin. By giving the drug and seeing a response during the time that we administered it, we do know that our agonists or antagonists suggest a common feedback with dopamine with prolactin in the elephant. Our dopamine agonists and antagonists certainly did normalize our prolactin secretions. However, we did not restore gonadal function. We want to point out that we did in one cabergoline-treated female, we saw one normal cycle after we ended treatment, but then she went right back to flatlining in the times to follow, or the months to follow. There were certain, we could have done certain things better, I should say. Certainly the lab had established a cabergoline dose that worked previous to our treatment, but we do suspect that perhaps if we would have given it in a cyclical regimen like we did the domperidone, we may have had better efficacy with restoring gonadal function. But speaking of gonadal function, we did not have any ultrasound data. The majority of these cows on the study were not trained for ultrasounds, and we did not have that. So in the cabergoline group that I showed you, that in the treated females where we did see significant increases in progestogen, serum progestogen concentrations, we have no evidence that that came from an ovarian origin. It certainly could have been from an adrenal origin, and we want to acknowledge that. So going back to the fact that we see these two conditions common clinically in the human, where do they come from? Where do they start? So in the human with hyperprolactinemia, we certainly do see a contributing factor physiologically. Pregnancy and lactation, not the problem in the elephant, right? Pathologically, we see tumors, and in a lot of our females, when we do have deaths, we're not seeing necropsies either done, or we're not getting tissue samples of the anterior pituitary, where these tumors may be. Primary hyperthyroidism, if you think about what I showed you with the 2004 paper from Brown et al., the thyroid hormones were not different. So we can make some deductions that then thyroid issues are not the problem in these elephants. But what really piqued my interest was the pharmacological component of this, to which we've not looked at. We know in the human things like anti-inflammatory medications, pain medications, And proton pump inhibitors, when given long-term, they can cause hyperprolactinemia. With the low prolactin, we have a genetic component to this. Again, a pathological component in that we have tumors, hypothyroidism, and also infections such as tuberculosis or histoplasmosis that can cause this condition. And then we see this pharmacological contributing factor as well. So in this case, serotonin agonists, vitamin B6 given at large doses, and then diuretics can cause this. So this is a very complex problem, and it has been ongoing for an extremely long time. A lot of groups around the world have contributed to this knowledge, and we haven't quite figured out what's going on with these captive females yet. We recognize that we need to continue monitoring elephants for reproductive status to look at those endocrine profiles, but we also need that ultrasound data. Without it, we have no idea what's happening at the ovarian level. Certainly during necropsies, we need to make sure that we're looking at the anterior pituitary for prolactinomas, which could either be stimulating the overproduction of prolactin or causing it to not be able to be synthesized or secreted. And then certainly the influence of pharmaceuticals. So in our zoo elephants, we do have inflammatory issues, we have pain medications that are given to manage that, infections, gastrointestinal tract disruptions, and so they are giving these medications that are known to be endocrine disruptors in other species. Edwards et al. In 2019 looked at housing and management styles and how they are associated with clinical health events. And so certainly that's something to take into consideration. And unfortunately, this condition persists. Brown et al. In 2016 saw that in our population of AZA-accredited zoo elephants, that now we're at about 51% that have these acyclicity abnormalities. So this is continuing to be a problem. So again, a lot of knowledge has went into this, but there is more places to look. And certainly for me, I'm thinking about endocrine disruptors. So whether it be a natural, a chemical, or a pharmaceutical component to this, if you think about how we gave those medications and while those animals were receiving the agonist or antagonist, in 3 of the 4 individuals, we saw reactions to those medications, but the minute we pulled them out of that system, it went right back to those pre-treated concentrations circulating of progestogens or prolactin. So that to me suggests that there's something else driving this. So with that, I'd like to thank Morris Animal Foundation, Pfizer, and Equitox Pharma, also the Smithsonian and University of Central Florida. We would also like to acknowledge that in the theme that we started with cancer, we actually lost D. Cross during the preparation of the manuscript to pancreatic cancer. So that kind of ties it all together that, you know, it affects all of us. And so the fact that elephants that we saw previously are going to contribute positively to that realm of research is quite good. So with that, are there any questions?
Great. We have